Congratulations on such a successful oncology meeting. Thanks to you.
I would like to show my gratitude again for Professor Cheryl Shields, Professor Jerry Shields, Professor Goto for helping me to organize this course. We have a successful meeting and I hope everyone enjoy. So I'm going to present my mystery case. She knows everything. So the first case is 26 years old male. He's a doctor, presented with floaters. So this is the eye examination. The optos photo shows that he has the very large choroidal mass with vitreous pigment. His vision is 20/40. The thickness of the tumor is 10 millimeters. So think about the diagnosis. The second case, 61-year-old male with 20/40 vision. He comes because of floaters, and then you see a lot of vitreous pigment and the choroidal pigmented mass. So at this time, I think you all agree that this is choroidal melanoma, but rarely that we see the pigment in vitreous like this. I searched the literature, and only one case report about massive vitreous pigment with choroidal melanoma has been reported. And that one was treated by diagnostic vitrectomy because they are unsure of the diagnosis, but proved to be melanoma after enucleation. So I talked with both patients and they denied enucleation. Most of our large melanoma, we treated them with enucleation, but both of them denied. So we discussed about the risk and benefits of endoresection. Both of them agreed to go for the surgery. So we performed pars-plana vitrectomy, endoresection, and put in silicone oil. And then at the end of the surgery, we cryo at the sclerostomy site, and then we put the ruthenium plaque over the tumor. When we do the surgery, we biopsy the vitreous first and separately send for a pathological diagnosis. And then we perform the biopsy at the main tumor to see if the tumor and the vitreous pigment is the same. So this is the surgery. So we cut the vitreous and then we send for pathology. We lower the blood pressure and higher the infusion pressure. The tumor invades retina, so we have to do the retinectomy before we do endoresection. We do not cauterize at the tumor at all. So after this, we still see that the pigment is over the retinal surface and it's not coming out. So I stain the IOM with membrane blue and then do the IOM peeling to peel the membrane along with the pigment. After that, we put in perfluorocarbon liquid to flatten the retina and do the perfluorocarbon liquid and silicone oil exchange. The plaque was applied after. So this is the sample that we sent for pathology. Both vitreous pigment and both tumor shows melanoma, malignant melanoma cells. This is the first patient, 11 months post-op. His vision is 2100. He has no recurrence and no metastasis. The retina is well attached under silicone oil. We just removed his silicone oil recently, and the retina is still attached. This is 3 months post-op of the second patient. His vision is 2100. There's no recurrence, no metastasis. You can see that there are some pigment over the optic nerve. We tried to remove it at the time of the surgery, but it sticks so firmly to the nerve, and we cannot remove it. So I just leave it there. With 3 months follow-up, it remains stable. So in conclusion, I presented 2 cases of massive vitreous seeding in choroidal malignant melanoma patients, which is very rare. And if we do the brachytherapy alone, I wonder if we could control the vitreous seeds in the vitreous, because it has been shown from our pathological report that they are malignant cells. So I propose that combined tumor endoresection and brachytherapy may be an alternative treatment to enucleation in these patients. Long-term follow-up is required to evaluate the risk of local recurrence and risk of systemic metastasis. If the patient agrees for enucleation, maybe I rather choose enucleation, because we don't know the long-term efficacy of endoresection and the safety. I will finish my talk here. We have 3 minutes for discussions. I would like to hear the opinions of the delegates and also the panel.
Thank you very much. I have a question. Did you check the histopathology of the seeding pigmented material?
Yes, we checked both. We sent it separately. So we checked the vitreous and we checked the main tumor. Both showed malignant melanoma cells.
Not the melanophage.
No, they show mitotic activities.
So when you have vitreous seeding like this, it's a sign that the melanoma has invaded into the retina, has broken through Bruch's membrane, invaded into the retina, and then it's seeding into the vitreous. Indeed, this is pretty unusual, seen in 1% or less of patients. So your therapy, you were sort of, the patients asked you to do this therapy. You know, we all have a little hesitation for doing endoresection because of the fear that it might shed cells outside the eye. It might be a good idea to have both patients seen by a melanoma oncologist and maybe put on systemic therapy just to protect them systemically. Another thing to keep in mind is some of the patients we've seen with situations like this, we've irradiated the tumor and then we've injected melphalan. So melphalan is actually very potent. We use it to treat retinoblastoma seeds, and it's very effective against melanoma. In fact, we have a protocol of melphalan intraarterial liver chemotherapy for patients with liver mets. So it's something you can keep in the back of your mind. If the seeds start to reactivate, you can try melphalan injection. I don't know how you would taper the dose because they both had vitrectomy. So you could probably go pretty low on the dose with the melphalan.
I would like to hear the comments from the audience as well, if you have your experience with endoresection or how do you manage it differently.
Okay. Thank you
Thank
very
you
much.
very much.
So let's move on to the next speaker, Dr. Minoru Furuta from Japan.